Okay, so I'm so excited to be here today to get to share my passion with you. I consider it to be something of both a science and an art, and that is of human labor and delivery. So a little bit about me. In addition to being a lifelong student, I'm also always working in medicine, and I volunteer as a labor doula up at the University of Utah Hospital. And so what a doula is basically just non-medical extra support for a laboring person. So this can involve breathing exercises, it can involve counter pressure, massage techniques, basic coaching, also acting as an advocate for your client and making sure that they fully understand everything that's going on. Sometimes things like consent and informed consent can go by the wayside when we're in a hospital environment. So my job is to make sure that the patient is fully aware of any possible interventions that might be necessary. So the Mayo Clinic, according to the Mayo Clinic, using a doula, such as myself, can decrease the risk of long labors, C-sections, and the need for pain medication. So at the University of Utah, it's great because the program that I volunteer under targets women who didn't have as much access to prenatal care. So these could be English speakers or English as a second language speakers. It could be immigrant women, chronically homeless women. So people who just didn't get as much care as we like to see. So as a doula, I often see a lot of fear surrounding the process of birth, but I think that education is power, obviously. I don't always go into the physiological terms, definitions, the nitty-gritty of things with my clients, but I do think that it's important that we understand these processes, the process of birth, and the mechanics of what goes into that so that we can better understand our purpose and our ability to help them through. Is that working? Okay, great. So first we need to talk about what labor involves. And as you probably know, labor is the preparing of both the child bearer and the baby for delivery of all the products of pregnancy. That includes the baby, obviously, amniotic fluid, and often forgotten the placenta. This usually occurs around 280 days after conception, so 9 months, but can be as early as 24 weeks for the fetus, the baby, to survive, although that does require a lot of medical intervention typically. Labor is a physiological process, meaning that we know that there are physical mechanisms in place. We'll be talking about these mechanisms and how they function together to perform this great act. For the most part, we'll be discussing what's termed normal, uncomplicated labor and delivery. Obviously, we all know that there are plenty of things that can arise during labor that can cause some complications. But for the most part, this follows pretty typical physiological processes. So when we talk about pregnancy, we can separate these into the physiology of the birth giver and the physiology of the developing fetus and the baby itself. So with the birth giver, obviously many changes occur as pregnancy progresses. And by week 12 of pregnancy, an amazing organ, my favorite organ, develops. It's called the placenta. And this is temporary. It's the only real temporary organ that we'll ever have. It attaches to the wall of the uterus, and it synthesizes hormones, pregnancy hormones, that can help kickstart labor as well. And obviously it exchanges nutrients between the mother and the fetus. So that goes through the umbilical cord, which consists of 2 arteries and a vein, so that's how the baby is getting its oxygen, its nutrients, everything that it needs to thrive. Another thing that you hear a lot about is weight gain during pregnancy. And for a woman who falls into a typical BMI, a normal BMI, they'll expect to gain between 25 to 35 pounds. And most of this is actually just the weight gained from the extra blood supply, placenta, the amniotic fluid, the baby themselves. Only 4 to 8 pounds of this is actual maternal fat stores. And since a pregnant person is now carrying another being, they can expect their blood volume to increase by almost 50%. So that's quite a lot of extra blood that a pregnant person is carrying around. And when we talk about the physiology of the baby, by the third trimester, most babies weigh between 6 to 8 pounds. But there are many reasons why you can expect this to be lower or higher. Say if the pregnant person is diabetic or is a drug user, you can expect that to fluctuate based on that complication. And with babies, some of us have heard about what's termed fontanelles. These are soft membranous spots on the head, and these allow the baby to descend into the pelvis to work its way through the pelvic canal later during labor. And so during labor, a physician or clinician or a birth worker can determine the position of the descending baby by locating these fontanelles and finding which way they're oriented to find out how the baby is oriented in the pelvis. And most babies are head first presentation, such as shown, but sometimes they can present shoulder, they can be breech or butt first, and this causes some complications because these presentations are a lot larger to be delivered, and they're not ideal to pass through the birth canal, but they also present the additional complication that the umbilical cord could be delivered before the head, and so that could pinch off the oxygen and the nutrients that are being delivered to the baby, and therefore make the fetus go into, or the baby go into fetal distress. So it's crucial that if there are these alternate forms of presentation of the baby, that the baby is delivered as soon as possible. So we divide this up into quite a few stages when we're talking about labor. It's not all just one thing. These are many different mechanisms going on, and they occur in different stages. So the first stage is pre-labor. So this isn't really a stage of labor, but it's a part of the warming up process that the body goes through to get ready for labor. Often you hear women talk about Braxton Hicks or false labor. These are contractions that are intermittent. They don't really fall in the typical pattern of true contractions where they're coming closer together, they're becoming more intense. So these just allow the uterus to basically practice contracting, to practice and tone up and get ready for true contractions. And this can sometimes cause dilation and effacement. And these are fancy terms that we use for the changes that the cervix undergoes. So dilation is the widening of the cervix. The cervix is just a sphincter that lies in between the vaginal canal and the uterus. And effacement as well, which is the thinning of the cervix. You can expect the cervix to get as thin as a piece of paper by time of delivery. And also lightening, the term lightening, which just describes the fetus or the baby engaging further into the pelvis to be closer to the birth canal. So that's termed lightening, but if you ask me, it's really more heavening. It's getting really, really deep pressed down there, quite uncomfortable. So now we go into early labor, which is one of the phases of the first stage of labor. The first stage is broken down into 3 subcategories. So early, active, and the transition. So we'll be talking about those as we go along. So science isn't completely clear on how labor starts. There's still a lot of research that needs to be done in that field. But the biggest theory is what's termed progestin withdrawal. And unfortunately, we had to cut about 20 minutes of this presentation where I go into all of the different hormones. So unfortunately, we don't have time to go into all of those different processes and mechanisms, but I'll go into them a little bit because you can't really talk about the physiology of birth without talking about tropic hormones or tropic hormone cascades. So progestin withdrawal is basically when progesterone, one of the hormones that are synthesized in a pregnant woman's body and in the placenta, inhibits uterine contraction throughout the pregnancy, but then estrogen is produced in place, and the estrogen spike causes an increase of prostaglandin production. And this signals smooth muscle contraction, and the uterus is a smooth muscle, so that begins that process of the uterine contractions. And also, when I need to talk about hormones, I need to talk about oxytocin, because that's really the biggest hormone that you can experience during labor. And so, again, this increases the estrogen that's produced, which then increases the prostaglandins. So we'll be seeing the oxytocin tropic hormone cascade throughout the process of birth. And this is what's termed, so this will continue until delivery. And something else that occurs typically in the beginning of labor is the breaking of the water. And so this is when fluid surrounds, the amniotic fluid that surrounds the baby will rupture, the membrane will rupture. This isn't often or always a large event. Sometimes women won't even notice when their membranes have ruptured, but sometimes that can be a big part of the first stage of labor. We also have the bloody show, which is when the cervical mucous membrane dislodges, and that is just a protective membrane that keeps any sort of foreign substances from getting into the womb. And then again, those uterine contractions from the oxytocin cascade. So, I think this is the old one. Okay, and then lightening again, as those contractions go further, they are basically pressing the baby down further into the birth canal. So we'll just skip over this one because it's really dense and really boring, and it will take up about 20 minutes, so we'll just go ahead and pass that up. And so comfort measures for early labor. This would include making sure that the pregnant person, the laboring person, is getting enough rest, enough sleep when they can. Eating and drinking is something that more and more hospitals are utilizing. They used to not allow you to eat or drink, and we're finding that that's an outdated practice. Most women can eat and drink safely throughout their labors. And we want to keep the laboring person mobile as often as possible, because this helps allow the baby to have further engagement up against that cervix. The further that baby is pressing up against the cervix, the more oxytocin is being released, and again, the more contractions are happening. So that would be an oxytocin feedback loop. Basically, the more oxytocin is being produced, the more oxytocin is being produced, the more oxytocin is being produced, the more oxytocin is being produced until we have delivery. So keeping the mobility could include using a yoga ball, could include walking up and down hallways, or just taking a walk, slow dancing with a partner or a birth attendant. These things really help the baby move into position for delivery. And as birth approaches, the laboring person may seem hesitant, they may seem excited, they may seem somewhere in between. So reassurance is really important, letting them know this is normal, this is a normal process of delivery. So oftentimes I like to bring out such visual objects as this diagram showing the descension and the stage of the baby. So let's say the last time they were checked, the nurse said, "Oh, you're at a -3," and now they're saying that she's a -1. This is just showing how far the baby is progressing in relation to the ischial spines of the pelvis. So now we get into transition, which is still the first part of labor, but it's the most intense portion. This is usually between 8 to 10 centimeters of dilation, and a woman might get very internally focused. They typically are no longer very vocal. They might not be receptive to questions. And so you can usually tell when this is approaching and when labor is imminent when a woman becomes silent and inwardly focused like this. So we can expect, as I said, dilation from 8 to 10 centimeters, 10 centimeters being fully dilated, and 100% effacement, meaning that the cervix is completely thinned out, and descension to a +3 stage into the pelvis. So some of the comfort measures to provide during active labor would include, one of my favorites is counter pressure. It's basically where you provide traction or provide a force, typically around the pelvis. This helps to open the pelvis up and allow for a wider birth canal for the baby to pass through, but it also ties into something in physiology that we term gate control theory. Basically when pain signals that are heading to the central nervous system are cut off by interneurons, so that the signal kind of gets scrambled and you don't feel pain as much. Massage is also a really big form of comfort when someone is laboring. This not only draws attention to the areas that are holding a lot of tension, it's good practice for easing into the pain of delivery as well. And it's really crucial that you pay attention to if someone wants to be touched during labor. So oftentimes they might not be able to say that something feels uncomfortable. So it's really crucial that if you're attending a labor, you pay close attention to their body language and make sure that you're keeping those constant lines of communication open. And breathing techniques, there are so many breathing techniques out there, but the purpose behind those is you really want to make sure that the client or the birthing person is keeping up their oxygen, keeping up their rest. It obviously takes a lot of energy to push a human outside of yourself, and so we really want to make sure that they're getting plenty of oxygen to those muscles as they're running this big marathon. And making sure that their breathing also helps to keep them from bearing down into their cervix, into their womb prematurely pushing, because this can cause damage to the uterus, damage to the cervix if they were to push before they were fully dilated, fully effaced. And positions are really one of the bigger parts of what we do as doulas. And again, depending on how medicated the patient is, if they have a spinal block, an epidural, they might not be able to do as many positions, but it's really crucial that we keep them moving to help, again, allow that baby to descend into the pelvis, and then to also make sure that the patient is comfortable. And so we now get into the second stage of labor. And this is where the patient, the laboring person, is fully dilated and can now begin pushing. And so what you'll want to do is coach them to push during contractions and only during contractions. That combined force of pushing and a contraction helps the baby to crown and descend through the birth canal. So the head crowns, and then once the head is delivered, typically the rest of the body is very quick to deliver as well. So some of the comfort measures that you can use during the second stage, this is obviously the stage that most people think of when they think of labor and delivery, is the delivery of the baby. So again, breathing is crucial. Make sure that they're breathing. Some people feel more natural pushing while they're holding their breath, and that's fine. You can absolutely do that if that's what feels comfortable to the laboring person. But we also try to encourage them to let out low, slow moans, and that just helps to keep their throat relaxed, keep their face relaxed, and that really helps keep them overall relaxed throughout the rest of their body and helps them ease into the pain of crowning. So most positions are conducive to delivery, require some sort of extra support, so that's where your birth attendants come in or your partner comes in. And this could just involve holding a leg back if they're supine, or allowing them to squat in between your knees and getting support from your knees. So making sure that you are offering these different solutions until you find something that really works for that person. You often need to work very fast because they're crowning, they're about to deliver their baby. So the woman will often know what feels best for her in that moment and will naturally take that position on her own. So this also allows you to be close to the most exciting part of birth. So you're actively helping, but you're also being close to the action. And laboring people might find themselves to be very scared or in a lot of pain. So it's crucial that we provide reassurance by saying things like, "You're doing great, your baby's almost here," keeping them focused on the goal. It's also a great idea, especially if they have an epidural block, to bring a mirror out, because they won't necessarily be able to feel that their pushing is doing anything. But if you bring a mirror out and you show that, the baby is descending, the baby is crowning when you're pushing, then they know that they're doing the right thing. So that's always a good idea. And then the often forgotten stage is the third stage, which is the delivery of the placenta. So once the baby is delivered, you still have to make sure that the placenta has completely separated from the uterine wall. And so this can bring additional pain. Sometimes clinicians have to make sure by force that placenta is completely gone. So contractions, those uterine contractions produced by oxytocin, will continue, and sometimes Pitocin, synthetic oxytocin, will be used just to make sure that the uterus contracts enough to fully release that placenta. Comfort stages to provide during the third stage. Obviously, the biggest goal is reached at that point. You have your baby, but we really want to encourage skin to skin. That's something that has come up in the last 10 years and is being practiced in more and more hospitals, where we have immediate skin to skin contact between mother and baby, unless there are some complications that inhibit your ability to do that. So if they know that the baby was in some sort of fetal distress during labor, or they're worried that there might be some complications, they might have to take the baby away to assess. But for the most part, in normal labor, we try to get immediate skin-to-skin contact with mother and child, just because it provides warmth, it provides a familiar heartbeat, and so it's a nice transition into the world. So again, that pain and discomfort during the third stage, oftentimes a practitioner might need to knead externally onto the uterus to make sure that it's contracting enough, or might apply external traction by using the umbilical cord to fully release the placenta, or if the patient tore during the delivery, they might need to use sutures to suture back up the perineum. So use similar techniques to the second stage if your patient is undergoing these types of discomfort and pain. And we're just going to skip all of these lovely slides because we cut them all. But as you can see, I have a lot more material that we didn't have time to get in, but I talk a lot more about mechanisms behind labor, again, those hormones and potential interventions and complications. So while the basic processes of birth and labor are well known, there's still quite a lot that we need to discuss and research. So hopefully, as we move forward with research, we can have a better understanding of these processes and mechanisms so that we can provide better care to laboring people. And that's all that I have. So I'll open it up to questions.
Come on, questions. No questions.
Yeah.
Can you repeat the question?
Oh, so he asked, why do people eat their placentas after delivery? So this is not a new phenomenon. Most mammals eat their placentas after delivery. They're full of really great vitamins and minerals. They're full of a lot of B vitamins. They're full of iron. It's believed that it can help stave off postnatal, depression. So it's basically a health thing. You can cook it. You can encapsulate it by drying it and dehydrating it and taking it in capsule form. It's still not super common, but I think in Utah it's getting pretty common. I don't know why, but Utah has like a really big push for naturopathic type practices around labor and delivery. But yeah, basically health benefits and to stave off depression, the baby blues. You had a question. Yeah, so I don't really have a research. Oh, I'm sorry. Yeah, he asked what were the ages of my research group, and what was the second part? Are there any complications dependent upon age? So I don't really have a research group. My research is anecdotal, so take it for what you will, but I do have peer-reviewed sources for my work as well. So my patients, I don't really consider them to be research. I just consider them to be my patients and my clients and who provide me with anecdotal experience of what birth is like. But there are definitely plenty of complications that can arise. So they say that after the age of 35, you are more at risk of, one, having a harder time getting pregnant, and two, you're at more risk of genetic abnormalities like Down syndrome. So that's not a hard and fast rule, but they do tell women to beware of that when they are at advanced maternal age. You wouldn't think that like 36 is like advanced maternal age, but that's clinically what they call it. And then obviously younger patients, younger women are definitely at risk of having higher complications just because, one, they might not have as much access to prenatal care, and two, they're smaller. So if there's trauma during the birth, that can cause some abnormalities as well. Yeah, great question. Yeah, that's a great point. Oh, sorry, repeat it. No, you're fine. So he asked if eating the placenta is necessary because is it necessary because we get a lot of those vitamins and nutrients in our diet already as a modern advanced society. That is absolutely true. Most people, as long as they have a combined and diverse diet, and they're making sure that their nutrition is a big part of their healing process, then it's not necessary, it's not required. It can be just like a multivitamin. You can consider it to be like that extra dose if you need it. You know, most people don't need a multivitamin, but some people like to have that extra assurance that they're getting all of those back. It also, something that I didn't mention was the placenta contains oxytocin and prolactin, which are pregnancy hormones. So they're thought just by ingesting those hormones again back into your body, bringing them back into your body, those are your feel-good hormones, and those are your cuddle hormones and your bonding hormones. So it's thought to help with that process as well.